Morning, good afternoon, good evening, everyone, wherever you are. I'm Dr. Masab Umair, and I welcome you all to today's webinar, which is on clinical management, diagnosis, and prevention of Mpox. So we use this platform to share, to bring different experts from Pakistan, and they share their thoughts on public health issues in the country. And before I start the webinar, there are some housekeeping rules. So this webinar is going to be recorded. And if you have any questions, we encourage you to put them in the chat box. And after the end of the talk, we will take a few questions from the participants. And secondly, after this webinar is completed, we'll share the recording of this webinar on Viral Insights as well, which is the YouTube channel. So let me introduce our today's speaker, Professor Dr. Naseem Akhtar. Professor Dr. Naseem Akhtar is a highly accomplished infectious disease specialist with over 25 years of experience. She holds an MBBS degree and advanced qualifications, including MCPS and FCPS in medicine and adult infectious diseases. Dr. Naseem is currently serving as head of Department of Infectious Diseases at Pakistan Institute of Medical Sciences. And she's also the focal person for Mpox. Dr. Naseem is an active member of several professional bodies such as Medical Microbiology and Infectious Disease Society of Pakistan and Infectious Disease Society of America. Dr. Akhtar has expertise spanning a range of services from managing complex infections and hospital-acquired diseases to leading antibiotic stewardship programs. Dr. Naseem, I welcome you, and please, the floor is yours.
Thank you very much, Dr. Masal, for a very nice introduction. And thank you very much for giving me the opportunity to talk about this very important aspect. So as Dr. Matsab has already explained, that I would be basically talking about the clinical diagnosis, management, and then infection prevention and control in Mpox. So before we see the slide share, I would just want to highlight that we all know that Mpox is a very rare contagious disease, and WHO has recently declared it as public health emergency of international concern. And after that, the government of Pakistan has also started taking active measures to control the local transmission of Mpox across the country. So as we know that Mpox is a viral illness, and this belongs to the genus Orthopox and the family Poxviridae. The disease is very, very common among MSM and other sex workers. And there are certain other high-risk groups, which I will be talking about later. So first, I will be just focusing on the different outbreaks which the world has encountered. I will just be sharing that the timeline for Mpox across the world. As we all know that the first case of Mpox was identified in 1958, and it was basically seen in monkeys which were imported from Singapore, and they were kept for research purposes in Copenhagen, Denmark. So here we found that Mpox was present in monkeys, and so the disease was labeled as Mpox disease or monkeypox disease. Later on, WHO just labeled this as Mpox just to, remove the stigma associated with the disease. And later we know that in 1970, first human case of Mpox was first recorded in Democratic Republic of Congo. And subsequently, there were multiple outbreaks which were diagnosed time to time. In 1980, we all know that smallpox vaccination was stopped, and it potentially reduced the cross immunity against Mpox. And ultimately, what happened is that the vaccine, which was protective in nature, it provided immunity to the patients who were already vaccinated. But later on, since it was stopped being used, then world witnessed different outbreaks of Mpox in different areas of the world. So in 2003, the first human case was recorded outside outside Africa, and it was found in USA, and it was linked to some exotic pet importation. Then in 2018, first imported human case was diagnosed in UK, Israel, and then Singapore. In 2022, there was an unprecedented global outbreak of clade 2B of monkeypox virus. Subsequently, from 2023 onwards, the outbreak is still going on. In mid-September, there was emergence of clade 1B Mpox virus in Democratic Republic of Congo. Subsequently, you can see that in early 2024, there was rapid increase in Mpox cases in DRC, and then it also included and involved the neighboring countries. And subsequently, WHO declared it as public health emergency of international concern because the disease was involving the neighboring countries as well. So this was about the global outbreaks. And here in the next slide, I would be just highlighting that how Pakistan witnessed the Mpox cases in the last 2 years. So it's important to mention over here that first case of Mpox was diagnosed in Pakistan on 19th April 2023. And basically, it was an imported case with a travel history. Then there were subsequent cases, as you can see from this timeline, that the very next case was diagnosed on 20th April 2023, then on 5th March 2023, then 4th May, fourth case was diagnosed again in 2023. Then 20th May 2023, the case was from Punjab. And then you can see that sixth case was diagnosed on 22nd of the May, seventh case on 18th of August 2023. And ninth case was, on 9th March 2023. And then on 15th of September, you can see the case was diagnosed from KPK. These are the cases which you can see from here that there were 9 cases which were reported in 2023. And subsequently, the first case of 2024 was diagnosed on 19 January. Again, this was an imported case. And up till now, in 2024, we have found 5 cases which are diagnosed to have monkeypox disease. And it is also worth mentioning over here that the sequencing which was done by NIH, it showed that it was clade 2B, and none of the patient belonged to the clade 1A with which the recent outbreak is going on. So this was a brief detail of all the cases which has been diagnosed from the Pakistan. It is important to highlight that all of these cases are imported cases. All of the patients have the history of travel in different Gulf countries, and there is no evidence of local transmission of the disease up till now. So this is brief summary. So I would be briefly highlighting about how Mpox cases present to us and how can we diagnose them. Even if the tests are not available, how can we suspect a case of having Mpox disease? So basically, we all know that incubation period of Mpox is usually 6 to 13 days, but it can vary from 5 to 20 days as well. So some of the patients, they may develop complication, but majority of them, they recover within a period of few weeks. And we all know that smallpox vaccination has been stopped being used since 1980 because the disease has been eradicated. So previously it was seen that disease was more common among those who were unvaccinated, 74% versus 39.5% in those who were vaccinated. So it's important to know that is everyone at risk of developing the disease, or there are certain groups of patients who can develop the disease. So it's worth mentioning over here that deaths have been reported in younger children who are less than 12 years of age, and immunocompromised individuals such as those who are having very poorly controlled HIV and having very high viral load of HIV, they are more prone to develop complications. And similarly, the patients who are engaged in specific risk behaviors, like the persons having MSM and pregnant ladies and other immunocompromised individuals, those who are having cancer, those who are on chemotherapy, and others with other autoimmune disorders. So how the transmission occurs? So it can be from, as we know that it's a zoonotic disease and it initially appeared among animals, and then it established itself in human beings. And now basically we are seeing that the outbreaks which are going on are basically because of transmission from human to human. So the transmission can be animal to humans, human to human. It can be vertical, like from mother to child, or it can be through contact with contaminated surfaces and equipment. And then secondly, the important thing is that the virus can also be transmitted through respiratory route if there is close face-to-face contact, and it can be transmitted through, respiratory droplets. I will be briefly highlighting that when to suspect a case, or rather, the point becomes very, very important because at the moment Pakistan does not have the local transmission of the disease, so it's not possible to screen everyone and to perform the costly PCR-based investigations on every patient. So we must know what is the case definition of the disease. So we basically strictly follow the disease at the moment. A suspected case is one who is basically is a contact of a probable or confirmed case in the 21 days before the onset of signs and symptoms. Important to note the period of 21 days because it is the incubation period. The maximum incubation period lasts for 21 days. So anyone who is a contact of a probable or confirmed case in the last 21 days before the onset of signs and symptoms, and then the one who presents with any of the following, like high-grade fever, headache, myalgias, body pains, extreme weakness. So this is one part of the case definition. And the second part is, or any person who presents with an unexplained acute skin rash, mucosal lesions, or lymphadenopathy. And skin rash may be, a single lesion, or it can be multiple lesions. And the lesion can start even from the face or from the anogenital region, and then they spread out to involve trunk and other body parts. So similarly, mucosal lesions may be single, may be multiple, and the lesions may be present in conjunctiva, in urethral area, penile area, vaginal areas, or lesions may be in the anorectal area. Anorectal lesions, they can also manifest as acute inflammation, like any patient who has the history of, travel and history of contact with a confirmed case and having inflammation of this area like proctitis. Patient can present with PR, bleeding, and pain. So, for which of the following common causes of acute rash or skin lesion do not fully explain the clinical picture? These are the different, diseases which can present with skin rash. So anyone who is presenting with any of the skin lesions and has the signs and symptoms after a contact with a probable or confirmed case and have the skin rash, whichever the rash is, we must keep a high level of, index of suspicion that this patient might be having Mpox disease. It's worth mentioning over here that even if the patient presents with any of these skin lesion, the test should be performed to confirm because co-infection can be present in addition to other skin diseases. So who is a probable case? A person who presents with an unexplained acute skin rash, mucosal lesion, lymphadenopathy, and skin rash may include single or multiple lesions. Again, the same definition which we observed for a suspected case. And person should have an epidemiological link to a probable or confirmed case. Patient identifies himself as a gay, bisexual, or MSM, and patient have multiple or casual sexual partners in the last 21 days. And patient also has detectable levels of anti-orthopox virus IgM antibody. So, and has a positive result for orthopox viral infection. So, important thing is that a probable case must have an epidemiological link with a positive case. And a confirmed case is the one who has been found to have Mpox by the PCR method or any other diagnostic test. So there are some other few definition. I will not be going into the details of those like discarded case. It's important that I should mention over here that what is the definition of a contact? This is very important because there are certain questions which arise that to whom we should label a contact. So any person who has been exposed to an infected person during the infectious period, that is we all know that this is a period beginning from the onset of index case first symptoms. And then it ends when all the skin lesions and the scabs have fallen off and person is having any of the following exposures. Number one, direct skin to skin contact or skin to mucosal physical contact, such as touching, hugging, kissing, and intimate or sexual contact. Contact with a contaminated material such as clothing or bedding, prolonged face-to-face respiratory exposure, and possible inhalation through respiratory route or eye or mucosal exposure to the lesion, like with the scabs or with the crusts. And it can also apply for the healthcare workers who are potentially exposed in the absence of use of PPE. Similarly, WHO has recently also provided definition for reinfection also, which was not in the previous guideline. So a person who currently meets the criteria for a confirmed case of Mpox and has a documented history of a previous episode of Mpox as a suspected, probable, or confirmed case, so person can be labeled as a case of reinfection. And similarly, the same applies for a probable case and for the confirmed case. So this was important to mention over here, that in the areas where the disease is very much prevalent, the possibilities of reinfection are also very much there. So coming to the relevant part of my talk is that how a patient presents to us. So basically, the initial phase of clinical features lasts for 1 to 5 days after an exposure. And these are the symptoms which usually appear at the end of the incubation period. So patient can have high-grade fever, headache, backache, severe muscular aches. Patient feels fatigued, and sometimes patients, they do tell themselves that they are having swollen glands in their neck or in the groin. And I would like to mention over here that it is a very distinctive feature of the disease, that lymphadenopathy distinguishes this disease from other pox viruses. So this is a very good slide to understand the pathophysiology or the evolution of the skin lesions in Mpox cases. So here you can see, if you focus on the left side of the slide, in first 1 to 2 days on the skin, the macules appears. These are just the areas of flat surface, or you can say some discoloration or appearance of lesions. And in another 1 to 2 days, these lesions become slightly raised or prominent. These are called papules. And in next 1 to 2 days, the fluid-filled blisters appear in the same lesion. In the same lesion, you can see that some material has appeared, and which is called a vesicle. Subsequently, after 5 to 7 days, a pustule appears, and you can see a very characteristic feature in here, that inside this pustule, there is a small pit. So these are called umbilicated lesion. Although there is a wide range of differential diagnosis of umbilicated lesions, but it is also a characteristic feature of Mpox. And in next 7 to 10 days, or 14 days rather, scabs appear, and these all nodular lesions, they disappear, and subsequently the scab also falls off. So it's important to mention over here that from the very beginning, once the patient develops the first ever symptom of the disease, patient becomes highly infectious and remains infectious till all the scabs have fallen off and new layer of skin has appeared. So these are, different lesions which are visible in the slide in different phases. Whatever I have shown you in the previous slide, it is a chronological order of the appearance of the rashes. And you can see that these lesions can be very much present in the anogenital areas, on the penile area, which usually our patients do not expose, or they don't tell about it because of the various reasons, because of the social and cultural values matter. So as a doctor, we must understand and try to find out, if patient does not have any lesions on other parts of the body, the history should be at least explored about it. This is a classical case of Mpox lesions, which you already always see on websites and in different clinical presentations. So you can see that all the lesions are similar, and they are in the similar phases of evolution, and they have central umbilication, which is visible in some of the lesions. So this is the classical presentation of the extensive Mpox lesions. Here again, you can see that multiple lesions are present. They are involving face, they are involving hands, and they are in the same stages of evolution. So in next 1 to 3 days, which is the second phase, fever subsides and the rash appears. What happens is that most of the time patients do not remember that they ever had a febrile phase or not, because it is usually for a few days, and it may not be that much prominent that the patient remembered. So once the fever subsides, the rash appears, and as I have already mentioned, it follows the different patterns like macule, papule, vesicle, pustules, umbilication before crustation, and then desquamation or falling off of the skin. Okay, so another important thing to know is that these lesions can vary in size. They can be very small, maybe 0.5 centimeter, or it can be up to 1 centimeter. or can be from a few to several thousand in number. Like as we experienced in our cases in Pakistan, they presented with very few skin lesions. They were present on face or sometimes on the arms or in other areas. I would be showing the pictures of those patients. But in the African countries, we have seen and witnessed that the lesions can be multiple, numerous. They can be in thousands, that they cover the whole of the skin surface, just like the burn cases in which all of the skin is involved, there are extensive burns. So eruption of the skin rash is classically described as centrifugal. Why do we call it centrifugal? Because it starts from the face and then it extends towards the palms and soles of the hands and feet, and then it involves the mucous membranes like the mucosa of the eyes, cornea. It can involve the mucosa of the oral cavity, and it can involve the genital area. And then the disease spreads and it also involves the trunk area. So lesions sometimes they only start from the genital area and then they spread out. Other clinical features include lymphadenopathy, which can be cervical or it can be genital, and patient can have extensive oral ulcer, which can lead to dysphagia, and ultimately severe lesions can lead to malnutrition, dehydration, and complications. So it's very important to take the proper history, establish an epidemiological link, because currently we are not facing a local transmission of the disease. So the history of travel is very, very important from the areas where the disease has already been confirmed. So it's very important once you suspect a case that patient is having skin rash, is suspected to have Mpox rashes. So it's important to know about other complications as well. We must, measure temperature, heart rate, blood pressure, respiratory rate, peripheral oxygen saturation. We should understand that how is the level of consciousness, whether the patient is alert or not, and what are their other biochemical tests like sugar, electrolytes, how is their BMI, and how is the pain scale, because these lesions are very, very painful and it's very, very difficult to manage the day-to-day activities once there are thousands of lesions covering the skin. There are a few important questions to ask from the patient. Is the patient able to eat or drink? Is the patient able to sit and walk independently? Has the patient any recent weight loss or any, since the onset of symptoms? Rash characteristics, I have already mentioned, but I would just want to like to highlight that we can also define the severity of the illness on the basis of lesions as well. So if there are less than 25 skin lesions, it can be a mild disease. 25 to 99 skin lesions, it can be a moderate disease. More than 250 skin lesions, it falls in the category of very severe disease. And if the exfoliation is present, involving more than 10% of the body, it means it's a very serious matter and patient can end up with various complications. Patient can also have secondary bacterial infections like cellulitis, abscesses, pyomyositis, and can have necrotizing fasciitis of the different areas of the body. So patient can present with seizures and coma if there is neurological involvement. Patient can have severe dehydration. And we must also check about the signs of perfusion if the patient presents to us with severe disease. Respiratory system should be evaluated. And then nutritional assessment should also be made by, calculating BMI, and then looking for the signs of malnutrition by using different, tools. Lab tests should be ordered to check for electrolyte imbalances, to see if the patient is in metabolic acidosis or not. Liver function tests, renal function tests, white blood cell counts, hemoglobin, platelets, PTINR, and albumin levels. These are all to assess the severity of the illness. So we all know that the testing is based on PCR because this is the gold standard, and confirmatory tests and the PCR from the skin lesion is very, very important. At the moment, we are accepting PCR from the skin lesions at NIH laboratory, although we can also do the nasopharyngeal and oropharyngeal swabs, but they should only be performed if there is high suspicion that somebody has a close contact with a confirmed or probable case, And if these tests come out positive, you can say that this person is having, Mpox. But it is quite possible that person who has still not developed rash can have a negative oropharyngeal test by PCR. So in that case, we have to wait and see till the rash appears, and then we have to retest from the skin lesion to confirm that this person is having Mpox or not. So another very important thing which I will just be highlighting is that one must wear the appropriate PPE while taking the samples, and we should collect 2 swabs from each lesion, preferably from different locations on the body from the lesions that differ in appearance. So if there is, if you are, taking sample from one lesion, take 2 samples, and if you are taking another sample, take it from some other lesion from other part of the body. So vigorously swab each lesion, avoid contamination by wearing proper PPE, use gloved hands to ensure adequate viral DNA is collected. Unroofing or aspiration of lesion is not recommended, and send swabs of the lesion material in viral transport media. So sterile, dry synthetic swabs should be used, and cotton swabs are not recommended because they interfere with the interpretation of the results. So basically, the material which has been recommended is polyester, nylon, or Dacron swabs. So this is important. So I was talking about the complications of Mpox in my previous slide. So as I already mentioned, there are so many lesions on the body that confluence of skin lesions can lead to bacterial skin infections like cellulitis or abscesses and all that. And subcutaneous accumulation of fluid in the crusting phase. It is very, very important to know that during this phase, patient can develop severe intravascular depletion and can end up with shock. And exfoliation of the skin lesion results in large area of the skins, which will be requiring surgical debridement and may need grafting later on. Patient can have severe pneumonia, severe respiratory distress, because this is one of the complications. Another thing which we have not, Alhamdulillah, in our patients, we have not seen any of the complications up till now. They only presented with skin lesion and they improved. But I would just be highlighting one of our cases in my subsequent slides, that how we observed that severe disease presentation can manifest. So patient can have corneal infections, which may lead to visual loss. Patient can have loss of appetite, severe nausea, vomiting, diarrhea, severe dehydration, electrolyte imbalance. Patient can have cervical lymphadenopathy. Up till now, we have seen that our patients presented with very small lymph nodes, and some of the patients even did not have lymphadenopathy. But in the African cases and areas where the disease is endemic, the lymph nodes are hugely enlarged. They are so much large that sometimes they lead to obstruction, and they can also end up with retropharyngeal abscess formation, respiratory compromise. Patient can have sepsis or septic shock, encephalitis, and may die. So lesions can be disfiguring, scarring, and blindness may be a subsequent long-term, complication of the illness. Okay, so there can be a long list of differential diagnoses like scabies, molluscum contagiosum, Kaposi sarcoma, measles. So I'm just going to highlight some of the pictures of my own patients, and these pictures has been taken with the consent from the patients. So they consented to share the pictures. These are the multiple areas here. You can see a different presentation where the lesions has gone up to the stage of scab formation. So these are some of the lesions which are present on arms and legs, and you can see they are in the pustular phase. Another patient who presented to us with the diagnosis of Mpox, and you can see a very clear picture of a vesicle which is going towards a phase of pustular appearance. So this was the involvement of the lung, because this patient later on presented to us with severe shortness of breath. And when we go for a CT scan of the chest, you can see it here that patient has a very classical halo sign visible in these CT scan slices. So you can see there is a central area of consolidation and it is surrounded by the ground glassing. So this is typical of, fungal infection in the lungs. And subsequently, when we did the tests, the beta D glucan for aspergillosis was positive. This is the involvement of the hands, and you can see that how much deep lesions are these. So here I would like to mention over here that what is differential diagnosis of this kind of rashes. So it is very much close to chickenpox. You can see that this is chickenpox. Here the lesions are in different phases of presentation. Like some of them are vesicle, some of them are macule, some are pustule, and some are very newly appearing lesions. So there is a mixture of different phases of evolution of the skin lesion in chickenpox. And here, other picture shows a bacterial skin infection. These are pustules in which the staphylococcal infection was confirmed. And this is cowpox lesions, a little flatter lesions in different, again, they are very much closely resembling to the mpox, but slightly different. This is folliculitis, infected hair follicles. This is pustular psoriasis. It looks like a bacterial infection, but it is pustular psoriasis. This is ORF, common in butchers. This is rickettsial rash, usually macular-papular in appearance. This is extensive Kaposi sarcoma in a patient with HIV. Seborrheic dermatitis sometimes can be confused with Mpox, as we are currently seeing in the outbreak that various patients are found to have a suspicion of Mpox, but Mpox tests are negative. Again, Kaposi sarcoma, purplish rounded nodular lesion on the hands and on body. So, important slide over here, how to differentiate it from chickenpox. So, Mpox is caused by Mpox virus and chickenpox is caused by herpes virus. Mpox lesions are very much less contagious as compared to chickenpox lesions. Mpox lesion can occur in animals as well. In chickenpox, it is human to human transmission only. Mpox rash is centrifugal, as I already mentioned, but in chickenpox, it first appears on the trunk and then it subsequently spreads out. Rash can be present on palms and soles in both of the diseases. In Mpox, single crop of lesion is present at one time. All lesion will be in the same stage of evolution. While in chickenpox, multiple crops of lesion can be seen in different stages of evolution. Central umbilication is seen in Mpox lesion and it is not seen in chickenpox. Lymphadenopathy is present in Mpox and not in chickenpox. Smallpox vaccine is used to prevent Mpox and chickenpox vaccine is used to prevent chickenpox. And chickenpox and mpox can coexist with each other. So this was an important slide. I would not be going in details of management, but we have to provide the supportive care to the patient, screening, triage, isolation, and then clinical assessment, risk assessment, and then management of the complications. Initially, you can give some antibiotics which can cover, staphylococcal infection, but subsequently, and depending upon the underlying disease, you can you have to select broad spectrum antibiotics. There are different antivirals like tecovirimat, brincidofovir, and cidofovir. Among these, tecovirimat has been found to be more effective to prevent the replication of the virus. And there are some drugs which are still in research. So TPOX is a capsule, and 3 capsules twice per day can be used for 14 days, and the treatment duration can be prolonged depending upon the severity of the illness and ongoing viral replication. IV immunoglobulin has also been used, but exact role is not defined. Vaccination is always there to, prevent the infection in the close contacts, in the healthcare workers, and the high risk population at the moment. WHO has not recommended the mass vaccination with the Mpox, with the smallpox vaccine currently, and only highlighted it for the high risk groups. So I will not be, taking much of the time focusing on it, but up till now, Pakistan does not have any vaccine available with us, and we might be procuring it for the high risk group only. So, there are, very important aspect is the infection prevention and control in Mpox cases. So, very important for the junior colleagues that contact and droplet precautions are very, very important. Airborne precautions should be only implemented if aerosol generating procedures are to be done. Like if you are doing some sampling, if you are collecting sample from the patient, like oropharyngeal swab or from the skin layers, or if you are, doing bronchoscopy or you're doing some procedures which are in which the mucosa is exposed. Equipment should be cleaned and disinfected as per national or facility guidelines, and the linen, hospital gowns, towels, and any other fabric items, they should be, handled very carefully and collected very carefully. All body fluids and solid waste of the patient should be treated as infectious waste, and patient isolated with Mpox should have measures put in place to, support patient interaction with the family and visitors. So I've already talked about the vaccination, and this is the vaccine which is commonly has been recommended, and this comes with the name of Imvamune or Imvanex. 2 doses 4 weeks apart are generally recommended. So because of the shortage of the time, I'm not going into the much of the detail. This was all about from my side. If there are any question, I'm there to answer.
Thank you so much for such a comprehensive and wonderful presentation. It was indeed very informative. There are a few questions asked by participants, but before that, let me ask you, what are preparations when we talk about clinical management of patients? So, what are the preparations done at the federal level and at the provincial level? You being an expert of infectious disease and head of the department at PIMS, and especially considering the fact that the lack of availability of tecovirimat, the antiviral, and also we have seen that tecovirimat has been found to be less effective against the clade 1b. So how is Pakistan preparing to tackle maybe a surge of cases in future, and how the management of patients will be done? Thank you.
Yeah, thank you very much. Very good question. Since currently we have seen that few of the cases has been, confirmed from Pakistan. So since then, the first case was diagnosed in 2024. On 15th of August, the government of Pakistan has taken several steps. Like the NCOC was restored, and there are daily meetings being done with the higher officials, with the DG of the federal health ministry and from the provinces as well, and all the stakeholders are on board, like from provinces, from the federal ministry, from the higher authorities, from NIH, NCOC, from laboratory perspective as well. And daily we are updating ourselves and to our country mates about the current situation and the global situation about the Mpox. It is very, satisfying to know that up till now, Pakistan has not observed any local transmission of the disease, and that is good. But at the same time, we are not here to close the eyes and just to see that when the surge comes, as we know that what happened with the COVID outbreak. Initially, there were few cases, and then we observed so many cases. So, all of us are aware that the government has declared various hospitals as designated hospital for isolation purposes, and focal persons from the different hospitals has already been nominated. And the border health services are very much vigilant for screening purposes at the airport. Although there are various questions about screening methods and at the airports, because patients who are coming from different countries, especially from the Gulf countries, they are being screened. Number one, verbal screening is done. We ask them about any history of fever in the last 21 days, any history of contact with a person who is found to have Mpox or suspected to have Mpox, and then these patients are there and then isolated, and they are accompanied by some healthcare worker, and they are transported to the hospitals where they are isolated in the isolation facilities till the test is available. It's not that we are having any plans to quarantine them. We just need to isolate them till their diagnosis is made. And since most of our patients, they are stable enough, they are, discharged home, and reassurance is being provided, counseling is being done. Testing kits are, available. And if any province is having, feeling any deficiency in the availability of the kits, the federal government is very much there to support them. And as far as PPE is concerned, all the isolation hospitals has enough PPE because in the COVID outbreak, everyone was well prepared. So COVID actually provided us an opportunity to, prepare well about any of the, new emerging and re-emerging diseases. For Mpox, I think these basic guidelines, SOPs are available on the website of NIH as well. And different awareness and teaching activities are going on, as this is one of those. Thank you very much for providing the platform for all. So I think the government is, trying to procure a vaccine as well as antiviral as well. Although it's very, it's not very easy task. And at the moment we don't need it, but we may need it in the future. So we are, focusing on it as well.
Thank you, Dr. Nasim. There is another question posted by Dr. Sadia. So she's asking, do we have an active surveillance system in place to capture Mpox cases in Pakistan? If yes, is the data publicly available?
Right now, as I already mentioned that because local transmission is not there, fortunately. So basically, we are focusing on all those patients or the individuals who are coming from different countries, and we are suspecting any skin lesions, or we are, as per case definition, whether the patient is having or not. So God forbid, if there is any local transmission, obviously the government is, having an active surveillance right now, but the system will become more vigilant and more robust in the coming days. But since at the moment, yes, active surveillance is being done, active screening is being done, and we are keeping an eye, especially at the borders at the moment.
Okay, so Dr. Ziba is asking, what are the national guidelines about waste disposal? And are there any IPC national guidelines available?
You can see the guidelines for Mpox, which were published by NIH, and they are available on the website of the NIH. Since this is a viral disease, and you know that all those IPC policies which were in place for COVID, which are in place for other different infectious materials, the same goes for the Mpox virus. So you can disinfect the surfaces with the routine disinfectants, and you can do the waste disposal as per your own hospital guidelines as for other viral diseases. So there is nothing something special for Mpox. So simple precautions of hand hygiene, contact precaution, wearing gowns, and then wearing simple face mask is enough for management of the patients. And similarly, as I already mentioned, that you have to wear N95 masks only in those situations where aerosol generating procedures are being done. Otherwise, simple face mask, gloves, gowns, which are the contact precautions that are enough for healthcare workers. They should maintain a distance of minimum 3 feet and maximum 6 feet. Distance should be there while examining the patient, and proper PPE should be worn, and all the waste should be, stored in a different place, in a separate place, and cautions should be taken that it should not be mixed with the non-infectious waste. As we, manage our other infectious waste in the hospital, same goes for the Mpox cases as well. And always infectious waste then goes to the incinerator.
Okay, thank you. So Dr. Amjad, he is interested in asking what is the mortality rate of Mpox? He's not mentioned whether he's talking about the death cases in Pakistan, but if you can explain mortality rate both at the national level and at the
Yeah,
global.
yeah. Yeah. At Pakistan, as of now, since the first case was in 2023, the last case we just had on 31st of August. Among these 14 cases, only one case died, and that person too was highly immunocompromised because of underlying HIV status. That was the main reason for the demise of that particular patient. So here only one death among 14. But as far as the case fatality rate is concerned, it has been variable, and it can be as low as less than 1%, and maximum case fatality rate which has been mentioned is 10 to 20% in severe cases and in the clade 1 cases, and it's less in cases of clade 2B.
Thank you. Dr. Mohammed Afzal from CDC US, he's asking why natural reservoir of Mpox is still unknown, and what research efforts have been done so far in this context.
Yeah, thank you very much. You know that Mpox initially it's a zoonotic disease, and basically it first appeared in the animals and small mammals, in the squirrels and prairie dogs and all that. And the disease is very much well established among the mammals, and it can be transmitted from human to human, as well as from the animals to human and from animal to animal. So it is an established fact that disease is present among the animals, and therefore it is also recommended that once you want to avoid transmission of the disease, if you have pets at home, you should avoid contact with the pets who are uninfected, because disease can be transmitted vice versa from close contact with the pets, from human to animals and from animals to human. So it's an established disease among both animals and humans.
Thank you. So just one more question from maybe my side. So you mentioned that all of the Mpox cases, they have been basically imported from Gulf countries into Pakistan. So can you please explain what are the measures taken at our point of entry just to control this importation?
Yeah, thank you very much. At points of entry, the border helpline services, they are quite active, and they are quite vigilant in active screening and surveillance of those cases. And the data is being shared on daily basis that how many suspected cases are appearing as based on the case definition, as per case definition. So all suspected cases are enlisted, and they are notified, and then testing is being provided on urgent basis, and the results are available in a day. And all those cases who are confirmed, they are also being notified, and active measures are being taken as far as their isolation is concerned, as far as their management is concerned, so that the disease cannot be transmitted to the community. And we are also providing instructions to the close family members of the patient to avoid contact, and we are also telling them that what are the guidelines, how you can avoid, the contact with a positive patient and avoid the transmission.
Yes, and just linked to this, Dr. Ziba is asking, so is Pakistan sharing this data with these countries about Mpox cases? With the Gulf countries, yeah.
The data, the all confirmed cases are being shared on daily basis to the WHO, and the data is available.
Okay, Dr. Nasim, is there any difference, in terms of signs and symptom between the two clades? We know that the fatality rate is different, especially the clade 1. It has a high fatality rate. But is there any difference in terms of clinical presentation?
Yeah, very, very good question. Clade 1 lesions are more extensive, more aggressive, and they they end up with a lot of complications. While the lesions with clade 1, with the clade 2, they are less extensive. They are maybe fewer in number, and the patient usually recover without any complications. So although disease can be severe in both of them, but if we compare the two clades, the patients who present with the clade 1, they usually end up with severe manifestations and more complications, and case fatality rate is also higher.
Yeah, thank you. So there is one more question from Dr. Afzal. How effective is vaccine against clade 1? And just I will add one more question to that. In the current outbreak, we have seen that there are a number of cases of Mpox reported in children, especially under 15 years of age in DRC. And while previously in 2022 outbreak, there was most of the cases they were reported in men who had sex with men. So what's the reason behind, cases being reported in children? And this is in addition to the question asked by Dr. Afzal on vaccine effectiveness against clade 1.
Yeah, thank you very much. Again, I would say that it's very, very important and good question. The vaccine is more effective against the clade 2 as compared to clade 1. So that can be a reason that that we may suffer from different challenges for prevention of the disease. Currently, in some of the areas, a mixture of clades is also being observed, like clade 1 and clade 2. So at least, although efficacy is lesser in clade 1, but still it provides some kind of immunity or prevention about the two clades as well, although it's less effective in clade 1. But still it can be used for the prevention of the disease. So this is the answer to the first question. And the second part was about
children being
what were the
infected.
questions of
Yeah.
children? The disease, the children are high risk groups, and they are always for various diseases. Children and the elderly people are always at a very high risk because they don't have a very good immune system. So among less than 8 years old children, the disease is found to be more severe. And the current outbreak, you have noticed that children are suffering more from the complications, and they have more mortality as compared to the other groups.
Okay, thank you. So just lastly, considering the fact that the vaccine it's not available, what are your recommendations in preventing, in making sure that the disease is prevented from being spread into Pakistan's community? So what are your recommendations?
Yeah, thank you very much. I think the first and foremost important thing is, having awareness about the disease, that how the disease is transmitted. As we all know that it is because of the very close face-to-face, face-to-skin contact, close mucosal exposure is needed for the disease transmission. It is not that contagious as there are other diseases, like I mentioned that measles is very contagious, chickenpox is very contagious, although it is contagious, but we know that it is a preventable disease. So we must focus on, prevention methods, because in the country like Pakistan, where resources are limited, where we do not have enough things available, vaccination is not available, antiviral is not available. So we, being a country with poor resources, we must focus on preventive measures like on proper hand hygiene. Number one, isolating the suspected case till the confirmation is done. And once the confirmation is done, obviously we have to take adequate measures to avoid the transmission. We must focus on hand hygiene every time we come in the patient's physical contact or in the patient's surroundings. And we must wear gloves and gowns when we are in close contact with the patient. We must maintain the distance between the patient. Patient should be isolated in a separate room with a separate washroom, and all the equipment and all the utensils and other things which are being provided to the patient, they should not be shared with others, and they should be thoroughly cleaned and washed, and should be dedicated to that particular patient till the patient is completely recovered and all the skin lesions have been healed. So this is very much important to know that from the beginning of the symptoms till the resolution of the symptoms, when all the skin lesions have been resolved, all contact precautions should be made, and face masks, the simple surgical mask, should be worn every time we come in touch with the patient or come in close proximity to the patient.
Thank you. Thank you so much, Dr. Naseem Akhtar. It was a pleasure having you. I think it's the importance of the topic. We can see that there were more than 90 participants who have joined us. So I really thank you for sharing your expert opinion on this important topic. And as I mentioned previously, so this webinar was recorded and it will be shared on Viral Insights. So if anyone is interested in watching it again, they can see it from there. I'm also grateful to all the participants for joining this webinar, and hopefully we'll make sure that we continue this activity in future as well. So thank you, everyone, and really thank you, Dr. Naseem, for taking time out.
Thank you very much.
Bye.